So thank you, Dr. McGee. Welcome to the RCC Head and Neck. We're very happy to have you with us. So for Philippine residents, Dr. McGee is affiliated from the Mayo Clinic in Arizona, and she is actually the Residency Associate Program Director. And so you're very lucky to have her today to teach you about the level 5 nodes.
Well, thank you for the very Today, what we're going to be discussing is how to contour level 5 within the head and neck cervical chain. I was able to listen to Dr. Patel's lecture with you guys on Tuesday. I apologize, I did miss the level 1 and level 2 lecture prior to that. So hopefully we'll be adding to what you guys have already learned the last few sessions, and then hopefully maybe even tying in a few concepts as well. So as we get started here, the objectives for today is we're going to review the anatomic borders for level 5. We're going to review the primary echelon lymphatic drainage patterns for head and neck tumors as they pertain to level 5. And we're going to review the relevant OAR in the vicinity of level 5. So before we get started, I just wanted to set some ground rules. I wanted to just make sure that everyone realizes and understands that I intend, as well as I know Ben and Rachel intend, for this to be a safe learning environment, free from judgment. I'm not judging any of your answers. I really hope as colleagues, you're not judging each other either. The reality is, if we all want to learn and improve upon our skill set, we first have to acknowledge that we don't know things. And in the setting of going through medical training, that can be uncomfortable because there's a lot of pressure, both from other people within medicine, as well as the pressure we put on ourselves to really strive for excellence and be perfect. But the reality is, when we are going through that process of learning, it's okay not to know the answers. It's also okay to give an incorrect answer. There's value to being wrong. Oftentimes, you're more likely to remember your mistakes and learn from them versus just memorizing the right answer when you forget it 2 weeks later. So it's just important that all of us are aware of these aspects of the learning process, and I really hope that by reviewing these things, it really will encourage people to be open, be present, and participate today. So as someone who teaches our residents how to contour head and neck cases, I always get our residents during their PGY 2 year, after they've just done an intern year and are coming into radiation oncology when this whole field still seems like a foreign language. So I'm very used to working with residents at a level where they really know nothing, and my goal is to really start from the bottom and build up. So I have that same expectation for everyone here. I don't expect everyone to know all of the answers. So with that in mind, let's get going. So first of all, when we're thinking about the lymphatic levels, level 5, at least levels A and B, which is traditionally what surgeons and radiologists and radiation oncologists have thought of level 5 is the posterior chain, or the posterior triangle that you learn about way back when you're doing gross anatomy during your first year of medical school. So as a reminder, the posterior triangle is located posterior to the sternocleidomastoid muscle, and especially along the inferior aspect of level 5, it surrounds the spinal accessory nerve as well as the transverse cervical vessels. As we're thinking about borders of level 5A and 5B, we're going to go through the superior, inferior, medial, lateral, anterior, and posterior borders. So as I think about my borders, I like to sort of tie things back into other lymph node levels, because that helps to solidify things in my memory. At least personally, that's how I learned this. So with that in mind, what other lymph node stations in the cervical chain use the hyoid bone as an anatomical boundary?
How about?
Hi, good morning. I think it's level 2 and 3.
So that is correct. That would be one example. So the boundary between levels 2 and 3 is defined radiographically by the hyoid bone. Now, if you remember, Louisa had just answered the question for the superior border of level 5. We use the cranial aspect of the body of the hyoid bone. Do we use that same definition for the boundary between levels 2 and 3? Very good. Excellent. And then there's one other lymph node level that uses the hyoid bone as an anatomical boundary. Does anybody know what that is? So the superior border of level 6A specifically is also the caudal edge of the body of the hyoid. So that's something, when I think about that, I like to clarify these in my mind so that we can help to solidify these pieces of information. So going back to the level 5 borders, what is the inferior border of level 5? And I guess specifically level 5B.
Benedict Chrysostomo, can you answer that?
So radiographically, do you know what we use to define the border, the inferior border for level 5B? So it's the plane inferior to the transverse cervical vessels. So all of these lymph node stations, when you look at the definitions, I think it's important to realize that the definitions have evolved over time from surgical-based anatomy to two-dimensional imaging anatomy, and now to 3D imaging anatomy. And so I think the answers that we were given before is, as the surgeons were dissecting the neck, traditionally they felt they were dissecting all the way up to the skull base. We know that's not necessarily true, and so we've modified the way that we define the lymph node levels for imaging-based guidelines, and that's the same for the inferior border as well. So currently, the radiographic definition for CT-based anatomy is the plane inferior to the transverse cervical vessels for the inferior border. What about the anterior border of level 5? Does anybody know what that is?
That would be the posterior edge of the SCM.
Absolutely. And then to tie this back to some of your other lymph node anatomy, what other lymph node levels use the posterior border of the sternocleidomastoid as an anatomical boundary? And 2, very good. So levels 2, 3, and 4. The posterior border of levels 2, 3, and 4 is the posterior aspect of the sternocleidomastoid. What is the posterior border of level 5? Anybody? Very good. And the lateral border? And then in some CT cuts, the skin we'll use. And then what about the medial border?
Scalene's muscle.
Yeah, the scalenes and then the levator scapulae. And then important to note, surgically, level 5 is divided into the upper and lower level 5 by their respective anatomic location compared to the caudal edge of the cricoid. As you're scrolling through a CT, how do you determine that you're at the caudal edge of the cricoid? I know Dr. Patel went over this with you guys earlier this week. Does anybody remember the answer?
When you start to see the esophagus?
Correct. So it's important to remember that the cricoid cartilage is a full 360 degrees. And that's different when you're comparing the tracheal rings. So the tracheal rings, those cartilages exist only along the lateral and anterior aspects. So there's no posterior aspect. It's not 360 degrees. So it's very easy to see the esophagus bulging right into the trachea. So as you're scrolling through that CT, you're looking for the cricoid cartilage. That is a full circle, a full 360 degrees. And then as soon as you do not see cartilage posteriorly, then you know you've reached the bottom of the cricoid. Very good. So what lymphatics have drainage to level 5A and 5B? Or another way of asking that question is what would be the superior continuation of level 5? So traditionally, what do we think that is?
Is it the level 7, the superior extension of it?
So traditionally, when we're thinking of the superior extension of the posterior drainage of the neck, most commonly we're thinking of levels 10. So the retroauricular region, which is 10A, or the occipital region, which is 10B. Another important consideration is level 2B, and we're going to go over this in the next couple slides because according to the current CT-based atlas, all we now have is level 2, and we're not necessarily splitting that into levels 2A and 2B like we used to. All that being said, I think it's important to understand that, so we're going to go over this. Traditionally, if you look at the lymph node levels as defined by surgical anatomy, Like I was saying, we have level 2 split into 2A, the anterior aspect, and 2B, the posterior aspect. The anatomical structure that we used to divide 2A from 2B was the spinal accessory nerve. Now, as we all know, the spinal accessory nerve, while it may be visible to the surgeon while they're in there dissecting out the components of the neck, this is not something that we can see based on CT delineated anatomy. So traditionally, since we could not see this based on CT, when the atlas was first developed, the new guideline was to use the posterior edge of the internal jugular vein. So basically, the way I was trained to approach this is if you see a level 2 lymph node that's anterior to the IJV, or even if it's lateral to and posterior to, but still touching the internal jugular vein, we would consider those lymph nodes level 2A. Anything that was in level 2 but posterior to the posterior edge of the internal jugular vein, where you could see a very clear fat plane separating your lymph node from that blood vessel, we would consider those lymph nodes to be 2B. So the reason this becomes important is as we were developing these atlases, many of the experts were arguing to keep this separate because it was felt that this represented the posterior cervical chain. So these are those spinal accessory lymph nodes. So the reason, at least in my mind, it becomes useful to understand this delineation really and truly is not necessarily for contouring, but as you're thinking about how to approach workup of patients who may be presenting with lymph nodes with an unknown primary tumor. So here in the CT example, we have this nice normal lymph node with a fatty hilum in level 1B. We have this grossly abnormal jugulo-digastric node or level 2A node, and then these shoddy little lymph nodes back here would be considered level 2B. So this is a patient that I just had under treatment who completed a few weeks ago. This CT scan was performed prior to his surgery back in February. What we see here is a very grossly enlarged left level 5 lymph node. It's centrally necrotic, peripherally enhancing, and based on imaging, there's obvious extranodal extension. So it looks like the tumor's invaded through the capsule. We see a lot of fuzziness in the fat plane, and it even looks like it's invading the muscles in the posterior neck. So as you're looking at this, and this gentleman presented with lymph nodes only, what primary sites would you want to consider in someone who's presenting with lymph nodes in the posterior chain like this?
Yeah, I'll think of maybe NPCA primary or a hypopharynx primary.
So traditionally, the two things that should be on your differential for the posterior chain would be nasopharynx and then a cutaneous skin cancer of the posterior scalp or neck. And so now in this patient, like I was saying, he did just present with grossly abnormal lymph nodes, which were biopsy-proven squame. Now in him, we actually had a very recent history of cutaneous skin lesions of the posterior scalp. He'd had 2 separate skin squames removed in October of last year. During the process of being worked up for that surgery, he was found to have leukocytosis. Long story short, he ended up being diagnosed with CLL and was undergoing chemotherapy. So in his immunosuppressive state, he unfortunately had a very short time interval to failure between having surgery on the primary site and being node negative at that time to developing grossly abnormal lymph nodes within a few months. This is that same patient, only a representative CT slice that's a little bit more superior to what we were just looking at. And here we see not only did he have that level 5 node, but also these level 2B nodes back here. So this is a patient, I think, that exemplifies this point that as we're considering level 2B, we also might want to be thinking about that as being part of the posterior cervical chain drainage. So again, if you're having somebody present with level 2B nodes, we really need to be thinking about nasopharynx or cutaneous primaries of the posterior scalp and neck. As far as the most common primary sites with lymphatic drainage to level 5A and 5B, again, we've already mentioned the nasopharynx as well as those skin squames. The other things to consider would be oropharyngeal primaries or thyroid carcinomas. So after going over the anatomical borders, next we're going to review some CT-based anatomy as they pertain to the borders. So what we're going to do is answer the questions on the following slide. So here's the first one. Which CT scan represents the superior border of level 5? And so if you had to describe the anatomical landmark that you're looking for, what's the anatomical landmark that you are looking for? So we're looking for the level of the superior aspect of the body of the hyoid. So it's sort of hard to tell sometimes when you're looking just at representative slices and you're not able to scroll through. But what we're looking at here, we have the hyoid bone represented here, and then this is actually the very top of the body right here. So I selected A. B is supposed to represent more of the middle of the hyoid body, whereas C is the inferior edge of the body of the hyoid, and then D, we have the superior edge of the thyroid cartilage. What about this next one? Which structure, so we're going to look at the structures marked by the red dots, which structure best delineates the anterior border of level 5? C, very good. So A, we have the jugular vein, B, the middle scalene muscle, C, the posterior aspect or the posterior border of the sternocleidomastoid, and then D, we have the transverse process of C6 marked. Which structure best represents the posterior border of level 5? The anterior border of the trapezius, and then don't let me fool you, this one actually has two answers. So as you're contouring out level 5, you're bringing this back to the level of the anterior border of the trapezius right there. And so if we look at the structures, A again is the posterior edge of the sternocleidomastoid, B anterior edge of the trapezius, C again is the middle scalene, D is the posterior aspect of the trapezius, and E is the anterior edge of the trapezius. How about this next one? Which structure represents the lateral border of level 5? Good job. So level C, on that slice, we would be contouring it to the skin. And then here where we're at a level of the CT on this patient where we've lost visibility of the trapezius, oftentimes as I would be contouring this slice, I would be using the lateral border of the clavicle here too. So the clavicle and the skin as we get further down. So again, A, that structure is the levator scapula, B is the sternocleidomastoid, C is the skin, D is the middle scalene, and E is the clavicle. How about the medial aspect of level 5? Yep, A, and then also D. So again, as you're contouring level 5, that medial border, so here's the posterior aspect of the sternocleidomastoid, so we're covering this fat space here, medially contouring along the middle scalene, and then coming back along the levator scapula there, just like we are in level A. And so I think this is an important concept. I will say that one error that I commonly see when I look at other people's contours or other people's treatment plans is, especially up here higher in the neck, there's a tendency to try to bring this contour in along this fat plane that's just deep to the levator scapula. But that's not correct. You have to remember that that's the medial border, not the lateral border. The plane below which of these blood vessels marks the inferior border of level 5? Not quite D, and this is again is tricky when you don't have the capability to scroll up and down. But remember, we're looking for the transverse cervical vessels. So if we're identifying the anatomy, A is the right jugular, B is the transverse cervical, C, we have that dot on the right common carotid artery, and then D is actually the left subclavian artery. So here we have examples from the most recent CT-based contouring atlas. So level 5 is in this orangish color. So again, contouring from the sternocleidomastoid all the way back to the trapezius, level 5 on this cut, and then 5C, which we haven't discussed yet, but at least once we get down lower in the neck, that's what level 5C will look like. This is a lady that I had treated who finished treatment about 6 months ago. So going back and contouring level 5 on representative slices of her CT, this is what I was able to come up with for this lady's specific anatomy. With the recent atlas, we've now added level 5C to levels 5A and 5B. Can anyone tell me what the superior border is?
Isn't the inferior border of level?
Cervical vessels, very good. Or another way of articulating that, just like you said, just inferior to level 5B. What about the inferior border?
I think it's the inferior border of level 4A, so it's 2 cms cranial to the sternum manubrium.
Very good. And then I already clicked through these. So the anterior border is the skin, and then the posterior border cranially, we're looking for the anterior border of the trapezius, and then around 1 centimeter anterior to the serratus anterior, laterally the trapezius, and then medially the scalenus, lateral edge of the sternocleidomastoid, and level 4A. So level 5C truly represents the lateral supraclavicular nodes. This is often sometimes referred to as the supraclavicular fossa or the triangle of Hoe. Clinically, we had defined this in the mid-70s, and as we were evolving with our definitions of lymph node levels from surgically based anatomy to 2D imaging-based anatomy to 3D imaging-based anatomy, this definition was omitted from the initial definitions. It first showed up back in 2006 with the update for lymph node positive neck disease. And at that time, it was just referred to as the supraclavicular fossa. So it wasn't necessarily given a numerical designation like it is today. So in 2013, this again evolved and now is included as level 5C with the definition that we just referred to on the prior slide. So the reason for this is if you were a purist and contouring just what was specifically described on the CT-based anatomy, when you would get down into the low neck, what would happen is you would have very narrow contours that would hug this anterior belly of the sternocleidomastoid muscle. So with traditional LAN, low anterior neck fields, the reality is you would be omitting coverage of a lot of the lymphatics with an IMRT plan compared to what we would have traditionally covered with an LAN. And so with these definitions, I think we still see a lot of variability with how this is contoured in the low neck. So both level 5 as well as 4B, I think, have a lot of variability. So personally, my thought process is, as I'm evaluating my contours, is not only do I look at my axial sliced contours, but I also scroll through on my coronals to make sure that my low neck is coming out laterally enough to really cover what I think that supraclavicular or that level 5C field should be. And I'm sort of comparing that and eyeballing it to what I would have wanted to cover with one of those. I agree, that's right. No, I have no idea. But we appreciate the input. Like I was saying, there's a ton of variability with how the low neck levels 4B and 5C are contoured. I think a lot of that not only has to do with our evolving understanding of it, but the reality is the anatomy varies very greatly from person to person. So I know Dr. Patel had already shown you these representative examples of these four CT scans in different patients representing that point that's 2 centimeters above the sternal manubrium. So we can see anatomically how different these are. And then I also just wanted to include these pictures here. So these scouts from these CT scans, what I'm just trying to show you here is really a lot of that has to do with how long the neck is from individual person to individual person.
So Dr. McGee, going back to that slide, how do you deal with some of this variability? Do you still use the same anatomic boundaries?
So I guess that was my point of trying to go back and really think about my contours and how they look on a three-dimensional plane. So because that low neck can vary so much, I'm basically going back and scrolling through my CT scan and looking at grossly to make sure that I'm covering what I would have wanted to cover with an LAN because there's so much variability.
I see.
So you kind of use the anatomical landmarks as a guide. I would say for the three of us here that treat head and neck, though, that's definitely probably the part of the neck that varies the most from person to person, even though we have our peer review process and we try to be as uniform as possible. And then I know you've been going over the OARs in relation to the lymph node levels that you've been learning. So level 5 being representative of the posterior aspect of the neck. The reality is we don't have a ton of OARs that we really contour here. So the only one that I've included is the spinal cord. It's important to note that it technically is defined as the true cord only. Cranially, we start this at the tip of the dens at C2. And then traditionally, if you look at the atlas definitions, we define the inferior aspect as 5 centimeters below the PTV. Really and truly functionally here in our department, though, what we end up doing is at least 2 centimeters below PTV for contouring. And then lastly, I'd like to just touch on indications for elective level 5 coverage. I think when you have positive lymphadenopathy in level 5, it becomes very obvious that you need to contour level 5 and include that in your target. But if we're covering level 5 electively, meaning we don't necessarily have gross nodes on diagnostic imaging, or if we're treating postoperatively, there were no nodes on path, you just want to electively cover it. Traditionally, the indications would be for a nasopharynx primary. So we cover level 5 bilaterally for the nasopharynx. Again, if you're thinking about a high-risk cutaneous squamous cell carcinoma in the posterior scalp or neck, you would want to electively cover level 5 if you're thinking about covering lymphatics. And then when you're looking at all of the other mucosal sites, oral cavity, oropharynx, larynx, hypopharynx, the traditional time that we cover level 5 electively is in the lymph node positive hemi neck. So for example, if you have a base of tongue primary, you have 2 lymph nodes located in left level 2. The left neck is now involved, so you would cover the left level 5. If the right neck is radiographically negative, then you don't have to cover level 5 in that specific case. So in conclusion, what we've done is we've gone over the, I guess, the borders of levels 5A, 5B, and 5C. Just like Dr. Patel had talked about on Tuesday, it's important to note that these are guidelines. I always recommend that as my residents are learning to contour, that they're evaluating their contours in all 3 planes of their CT. So make sure you're looking at axial, sagittal, and coronals. I would argue that's useful regardless of what disease site you're treating. And then we didn't really talk about this today, but I know Dr. Patel was touching on don't compromise target coverage in order to avoid overlaps with the organs at risk, such as the brachial plexus. The brachial plexus also pertains to level 5, so I had wanted to include that in here and remind you about that today. I think he made a very excellent point that a lot of times when we are treating patients who have cervical lymph nodes directly adjacent to where the brachial plexus is located, that we're still going to treat that to full prescription dose. The way that I approach that with my dosimetry team is that I'm willing to accept prescription coverage to the brachial plexus right at that level. My goal is to limit hot spots and limit the absolute dose of the hot spot, and then also limit the volume of brachial plexus getting a hot spot. But obviously, if we have to treat those lymph nodes to 70, we're never going to meet our goal of a Dmax to 66 gray for the brachial plexus.